Good morning, everyone. As Anna said, I'm Melissa Jennings, and I'm the Director of Special Projects and Operations at the Knowledge Institute on Child and Youth Mental Health and Addictions, a partner in this conference. Thank you, Anna, for reminding us of where we've been and setting the stage so nicely for the conference today. I'm pleased to introduce today's keynote speaker, Dr. Ben Chan, an assistant professor of global health at the University of Toronto and a leading figure in Canada on strategy and leadership for healthcare quality. Dr. Chan was the inaugural CEO of the Health Quality Councils of Saskatchewan and Ontario. In recognition of his work in spearheading improvement initiatives in chronic disease management, patient safety, and public reporting on quality, Dr. Chan was named in 2006 Canada's Outstanding Young Health Executive. Dr. Chan is consultant to the World Bank and has worked with the WHO and foreign governments in 25 countries spanning 5 continents. He advised on the national quality strategies for Georgia, Uzbekistan, and Kyrgyzstan, and led or supported quality improvement projects on hypertension, diabetes, and childhood growth in Kazakhstan, Tajikistan, and several Caribbean countries. He is currently developing for the World Bank a tool to assess quality improvement capacity to identify priorities for investment. Dr. Chan is also an experienced primary care and emergency department physician and has worked in over 70 rural communities across Canada. And he was the physician for a remote First Nations community in Northwest Ontario, where he helped establish opioid addiction treatment services. He holds a BSc and MD from the University of Toronto, a Master's of Public Health from Harvard, and a Master's of Public Affairs from Princeton. Our keynote discussion will be moderated by Noshaba Degani, Chief Quality Improvement and System Performance at CMHA Ontario, and one of the co-leads of the Excellence Through Quality Improvement project. Please submit your questions through the Q&A function located on the Zoom webinar toolbar at the bottom of your screen throughout the keynote presentation, and Noshaba will pose them to Dr. Chan.
Great. Thank you. Thank you very much, Melissa, for that very kind introduction. And I just wanted to thank the organizers and to AMHO and to Ontario Health for this event. As you had heard, most of my work in the last decade has been international in scope, but I take a keen interest in what happens in Ontario, and I'm really delighted to see the incredible amount of progress that has been taking place in recent years, and the amazing work that's been done by this group, by this the E-QIP program. I think is you've got some fabulous resources that are now widely available to the entire healthcare community across the province. So, bravo! I'm really thrilled to see that. Can we have the slides, please? Great. Thank you. So I wanted to have I'm delighted to have this opportunity to talk about the next steps of growing the quality improvement agenda. And as I was speaking with the organizers, one of the issues that come up is that in the mental health community, we are serving many vulnerable populations. So that could be vulnerable in terms of geography or gender or other socioeconomic group or ethnicity or First Nations, a community that I've spent many years working with. And sometimes in those settings, particularly more remote areas, Um, we are often working in low resources. And so how are we going to implement innovations and a broad quality improvement agenda in those settings? And this is an area, a particular question that I've had a particular deep interest in both right now in my current roles in supporting quality improvement in low and middle income countries, but also in my own professional medical career. I've always loved rural medicine and the opportunities of making changing people's healthcare trajectory in those communities. And so this is a question that's been particularly near and dear to my heart. Next slide, please. I'll move that. Um, so the modern QI agenda, just, I think we all know this, and everybody who's studied in the E-QIP program will know that there are multiple dimensions of quality that we want to optimize at the same time: effectiveness, safety, patient experience, efficiency, equity, and access or timeliness. We know that we want to create a culture where we're focusing on system design problems and not simply blaming people. And I think that's been well established. Sometimes we fall back on our old habits or thinking from time to time, but I think we made a lot of progress in that direction. We want to make sure our system is driven by measurement. We all know we can't measure what we can't improve what we can't measure. And Greenberg gave great examples of a number of areas of investment in the measurement infrastructure. And we want to be motivating people to change. And we want to do a lot of testing and learning, testing of different ideas and continually refining the way that we deliver care until we find something that's optimal or continue to optimize it over time. And if I were to look even in my own lifetime, it's been fabulous to watch the evolution of QI right from the early 90s. Maybe I'm dating myself from the early 90s when I was a graduate student. That was at a very early stage in the development of the quality improvement movement. I had the opportunity to study with some of the leaders of that movement at the time in my master's program. There were these demonstration projects based in, many of them led by a group at Harvard on how to apply industrial style quality improvement into healthcare. There was, of course, the landmark to Era's human report in the U.S. on bringing forward the issue of patient safety and harm. And then throughout Canada in the early 2000s, a whole set of supporting structures to build up quality improvement capacity. The Health Quality Council, which I had the opportunity of leading, Canada's first Health Quality Council, but then organizations such as the Canadian Patient Safety Association and health quality councils or their equivalents in numerous other provinces, and OHQC, which eventually became Health Quality Ontario. IHI played a major leadership role as thought leaders in this process, certainly in North America, and came up with ideas such as the triple aim, which later became the quadruple aim, let's aim to improve a number of different issues at the same time: the health of the population, patient experience, reduce costs, and later also let's take care of ourselves as healthcare providers and watch out for our own well-being. We've seen a real proliferation of graduate programs in our major universities across Ontario, starting with the Quality and Patient Safety program at a certificate and then later a master's program at U of T. But thrilled that these programs have also been established at other universities, and these I think really broadly accessible online programs, online training programs. The Excellent Care Act for All Act was I think one of the most important pieces of quality legislation in the country, establishing the idea that this idea from IHI, the model for improvement. What are your aims, measures, and change ideas? We actually enshrined that into law. I mean, I think that's a pretty cool thing when you think about it. It's this core concept from IHI is now something that by law, every organization, healthcare organization is supposed to be implementing. I know I think that was at the time really groundbreaking for the government to think of that. And over time, the work that has been swelling up throughout Europe, throughout North America. There's in more recent years, I would say, a mass expansion and acceleration of attention towards quality in low and middle income countries. I marked 2018. For those who are working in public health and global health and quality, we affectionately call that the year of the three reports, because we had a landmark study from Dr. Margaret Crook, former Ontario physician who's at Harvard, in the Lancet Global Health series. The WHO, World Bank, and OECD had another landmark report, as well as the National Academy of Sciences and Engineering and Medicine in the US, led by Don Berwick. They all came up with with uh, 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 an amazing analysis of the shortcomings of quality and how addressing quality now needs to be one of the key strategies for achieving the UN Sustainable Development Goals on improving population health and achieving major improvements, such as in premature mortality for different conditions. So with that, what are some of the innovations? What are things that are happening, and particularly, what are things that are happening in to advance the quality agenda, particularly in resource-rich settings? Well, one, the amount of data that we have to work with now compared to 20 years ago in my when I was just starting my career is in quality is enormous. And I think in Ontario in particular, I would say that the province as a whole has taken a leadership role within Canada in making data widely available. Wait times data, for example, a lot of investment in safety, in patient safety, adverse events. And this is happening worldwide, that we have this data and we're able to present this back at a national level, at a regional level, and at an individual facility level, and better yet, at an individual provider level or a provider unit level on performance across a dashboard of different indicators to be able to present this as run charts or as comparisons between different peer groups to motivate people to improve. We've also seen the rise and the proliferation of decision support tools. So one of the key questions on quality and effectiveness is, are we implementing all the evidence-based best practices that we're supposed to implement? And it's hard. Those practice guidelines are often about an inch thick with 100 pages. It's incredibly difficult for providers to remember everything you're supposed to do. But now there's a plethora of different tools, decision support tools, to help us do that. There are checklists that are embedded into our documentation systems, either paper or electronic, to remind us, for example, what are the things that we should review each time we see a patient. What are the different questions, for example, in this example, that we should be monitoring about patients' symptoms and whether or not they are improving over time. And those decision support tools go further. The tech support, if it can help me advance this slide. Thank you. Reminders. It is incredibly easy for us to forget to do certain things. It's easy for us to forget that a patient is supposed to return or is supposed to have a test on a certain frequency. So we have lots of different reminders to help us stay on top of an increasingly complex clinical environment. And we have an increasingly complex system of alerts that about everything from adverse drug elections, allergies, or drug interactions. And taking that even further, other technological innovations, clinical decisions about things like what's the most appropriate drug to be prescribing for a particular patient who has a particular constellation of different symptoms or issues that they want to avoid. So if I have a whole slew of different SSRIs and other antidepressants that I may want to offer, which are the ones that are going to be best, that are going to minimize issues around weight uh, or sexual dysfunction or sleep disturbances, and I can use different tools to help me make the right decision. And that type of tool is only going to get even more sophisticated in the near future as we see the advent of AI into medicine. Patient engagement, that is one of our core dimensions of quality. So we want to make sure our patients, that we communicate well with them and that we understand their particular issues and we're designing the care around them. So a real move towards making the medical records widely accessible to the patient so they can see their lab values. But more than that, to have patients have the ability to upload their data and that can be everything from things like blood pressure and weight, but also things like symptoms and how they're feeling, which is particularly important in mental health. The area that I'm the most familiar with on ongoing management is self-management, and that's a that's a that's a methodology that's important both for chronic disease management as well as ongoing management of mental health, helping people set small, achievable goals and in developing their confidence, changes to their lifestyle or changes to their day-to-day routine that will result in some a kind of more healthier behavior, and keeping it super small so that people can feel, well, I did something, I made a change, and now I feel better, and now I feel more empowered to make the next little change. That's great, but that requires a lot of if to do this well, for many people, it requires some kind of regular periodic following up with the patient, somebody that they can, that's a floor for them that says, that can check, you set this goal to make this change, go out for fresh air for 10 minutes once a day. And here, this is our weekend check, our 1 week check. How did you do with that goal? So there's a sense of somebody providing accountability. Well, now there are tools and ways in which we can facilitate that type of change to help people improve their lives. Other things like scheduling, so mundane but super, super important to making sure that patients get the follow-up, that they can schedule appointments that are convenient for them, and then they can easily confirm whether or not they have that appointment and not get stuck on the phone for an hour trying to reach somebody and being put on hold. So a lot of movements towards online scheduling. So these are some of the things in which we are using different types of tools within our quality improvement processes to improve the way that we deliver care, and ultimately to increase our adoption of different clinical best practices, to increase access to services, to increase patient experience. And having worked in my past roles and in running health quality councils of Saskatchewan and in Ontario, there's huge variation in the capacity that different healthcare organizations have to draw on. All of these different activities to build quality improvement take time and resources and staff time. You have to remember that it's a mistake to think that somebody who has a full-time job in other areas, um, it will have a great amount of difficulty doing quality if it's done on the side of their desk. So if organizations, particularly hospitals, if they can have historically, I've had the largest quality improvement departments, and when you have a large quality improvement department, then you have much greater ability, obviously, to implement all of these different great ideas. It's great if you can have a vice president of quality and a medical director of quality and a quality manager, and you've got a small or a large team at your disposal, people who have certified green or black belt lean for healthcare or Six Sigma or other methodologies or IHI improvement advisor, whatever certification you can think of. And now there are vendors that will provide a suite of these different types of tools to integrate into your health information system. So that's fabulous if you can do it. But what if you're not one of those wealthy, relatively well-resourced, large institutions? Can you still do all of this important improvement work? So I want to pause for a moment and just take a quick poll. And so I'd like to understand my audience better. Um, how would you describe yourself and your quality improvement capacity? You look at all the things that I've talked about, all those dashboards, those decision support tools, those patient engagement or client engagement tools to have interaction back and forth, those scheduling calls. How would you rate yourself? Resource rich QI setting would mean everything I just said, you got it all, or almost all of it. Medium capacity, you got maybe a few things, some of these things, so you're building, you're not quite to there, but you've got you feel that you're making a lot of progress in a lot of things. Or are you a low resource environment, maybe in a smaller organization, you're feeling that, I have limited resources. I've got a small budget. I have staff that are trying to, do 5 different roles. They do quality and patient and safety and risk assessment and accreditation and deal with complaints and other management issues on top of that. And that I don't really have access to a lot of these tools that I've just mentioned. I'd love to see. Please vote we'll take a few minutes, and I'd love to know where you feel you sit on this spectrum. Sherry, do we have enough results to be able to show the results? Okay. All right. So this is really helpful. So we do have about 12% that are very fortunate. So and then power to you, and you've got great opportunities to continue on this journey. About half are in the medium capacity, so making some progress, but lots of opportunities to move forward. And about 40% that consider themselves a low resource environment or a small organization. And so I'm really glad to see this. So I hope I'll have something to share, particularly for that group that is particularly near and dear to my heart. So we do, in fact, have a diversity. That's exactly what I was anticipating as I was preparing this talk. So what are we going to do? What if you're not in a resource-rich environment? Are we just going to wait? Well, maybe we'll get more resources, or maybe some, we'll get some help. Are we going to do nothing and say, this is impossible to do with the given resources, or let's just do QI? So there are tremendous opportunities still to for those, particularly at that 40% group, there's still tremendous opportunities that you can undertake to improve quality in your particular area. And before I jump into those opportunities, let's just reflect it. So all these ideas sound great. Oh, well, now I don't have to think about all of these. The computers are going to remind me of everything I'm supposed to do. Well, what does some of the research shows us? Well, EHR-related alert fatigue. This is a huge issue. So we are bombarding our providers with so much information about what they're supposed to do that they're actually tuning out to a lot of these alerts as a defense mechanism, because you're feeling overloaded with this type of information. And here's another study. So evaluation of physicians' responses to medication-related alert override. So if you look at that bullet point, the majority of alerts were found to be inappropriately overridden in this particular study. So something is going on about, even in these resource-rich environments. And let's take this even further. How is our community, medical community, or our health provider community feeling? It says EHRs are contributing to physician burnout and the association of electronic health record use with physician fatigue and efficiency. If you search PubMed, there are hundreds of articles about how the impact of the digitalization of health has had on the quality of a professional life for healthcare providers, particularly, unfortunately, for family medicine. That you have, in multiple countries now, the providers are saying that this is adding an extra 1.5 hours of documentation time to their day-to-day work that they often have to make up in evenings. And we worry that people are exiting primary care. And it's now we're starting to hear more and more about just how big an issue this is. So even in areas that have a lot of resources, we have some problems with how this quality improvement agenda is being implemented that we need to address. So I don't mean to say a negative to the high resource to make the low resource QI people feel better, but it's an issue. There's some issues here that everybody needs to address. And I want to point out, and this is partly just my own anecdotal experience, what are the advantages of working in low resource QI or small environments? Nimbleness. If you're in a relatively small organization, you can pivot, you can make changes much more quickly. Collegial, when you are in a place where a lot of the different people, I have a much stronger relationship with people, and you are much more in tune with the issues and concerns of different groups, then that gives you an advantage of moving forward on your improvement agenda. And the fact that because there's just from the management suite to the people on the front line, there's just less distance in a smaller organization, and it makes it easier for you to stay in touch with what are the burning issues at the front line. So there are things that in your favor to that you can think about. How can I put this to good advantage? So what are some of my survival tips? And this is so I was a bit nervous about presenting this because this conference talks about innovation, but I'm gonna make a pitch here. Back to basics. Know the QI basics very, very well. I would rather that people here, instead of trying to learn, instead of trying to, what's a good analogy? Uh, Instead of trying to learn a blazing guitar solo from your favorite band, if you can play that your basic chords and your 3-chord rock, but do it really, 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 really well and really tight. Um, don't be don't estimate the power of doing these basics really well. And some of these core things, back to basics, define your problem clearly, and the priority, which is the 1 or 2 things that you really need to focus on. Look across your organization and understand what are your core business processes, and number them and name them, and think which they're going to all be important in different ways, but what are the ones that are the most important? What do I need to optimize and continually to improve? And just keep working all these 2 core tools that you find in the E-QIPs to find out what are the root causes, your fish bones, your process maps in particular, and use some simple tools to monitor quality, which actually might not be the data that is being fed to you automatically through different sources, which I will elaborate. And apply your PDSA cycles in the proper way. I'll make a brief point about that. And what I'm getting at here is, sorry, I skipped here. Okay, so first point here, define your problems well and pick your top priorities. Let's just do a quick review of our core dimensions of quality, and I contextualize this to some of the common issues and that I've observed in mental health. So access and timeliness. So what are the wait times for mental health services, or are there issues with the services just not being available? No provider, or it's too costly, there's out-of-pocket costs, or the providers are too far away. Safety issues, suicide, self-harm, harm to others, medical error, or assaults or injuries to providers. Patient experience. Communication is always, often the number one issue with patient experience, but we also still have issues with courtesy and respect, and the entire patient journey, whether it's organized around the patient or we've created a lot of inconveniences. Effectiveness. Are our treatments working? Are people's depression improving? Their psychotic symptoms for one of the target groups mentioned for schizophrenia, are those improving? Are they, is a level of functioning improving over time? Is there the treatment for substance abuse, is that improving? Efficiency. I'm going to spotlight in particular wasted provider time, redundant documentation or assessments, or excess documentation that's not really necessary. This is it's one of the things I feel as a healthcare provider. And equity. You can take any of these issues, any of these preceding dimensions, and are they worse by income level, education, rural, gender, age, ethnicity? And so, yeah, let's take a brief moment of reflection. If we can I ask you to give a vote? Which of these would you say is your number one concern? Good, lots of results coming in. Okay, I think we're getting to a pretty good steady state. So I see access. It looks like it's coming up as is the top, about just over a third, but effectiveness is the other major issue. Are the treatments working? And you also got patient experience as well, and safety. Okay, great. Now, I think everybody can see those results. Good. Okay. So let's just move on now. Uh, so another on this point of knowing the basics and practicing them well, developing a deep proficiency in process mapping. And I'm going to say something that's a little maybe I'm not sure if this is controversial. Yeah, I love lean, I love value stream mapping, I love the Kaizen. Those are all great tools, and for people who do this and do this well, that's a fabulous value added thing. But if you don't have that level of skill, don't underestimate your power of being able to transform quality within your own institution. And in terms of technology, go back to your blank wall, your yellow stickies, and your Sharpie. And the challenge is that I'm going to put forward is to be able to take those tools and reflect on what are your name, understand, and optimize your core work processes. So coming back to my earlier slide, in these relatively high resource QI environments, what's going on here? Why is it with all the resources for facilities that can do all of these more technologically advanced tools for decision supports, why do we have issues with people feeling burned out, or issues with people just going out and ignoring these different alerts and all this rich information that we are providing them? And I put this down to the basics. When all of these things were implemented, did we follow all these different areas? I mean, one of the common concerns I hear from frontline providers that we can't stand their electronic medical records. It's like, where was the testing that took place to see how we would actually use this in our practice, and how whether or not this would help or disrupt our workflow? So if it's not working, we got to go back and see, step by step, in what order does the doctor press certain keys and interact with the patient, and how can we make that much more smoothly? I read this and I ask this question: have we truly understood what the workflows are within the day-to-day work of a healthcare provider? And after we've implemented this technology or these tools, have we continued to monitor our process times and our error rates for these? The fact that this appears in like a peer-reviewed study where somebody actually had to design a study instead of having this data readily available is something that raises an issue with regards to how the basics of quality are being implemented. And have all the different process optimization strategies been considered in the implementation of these tools? And most importantly, when we look at our classic teachings from the model for improvement, for example, about aims, measures, and change ideas. On the measures part, we talk about balancing measures. Have we deliberately anticipated the unintended consequences, and have we developed balancing measures that actually try to measure the unintended consequences of our work? Because if those are huge, the project is going to fall apart after the QI team disbands, and whatever change you thought was great is not going to be carried forward. So again, getting back to basics, what does a typical referral process looks like? And this may be a bit of my perspective, since one of my primary interactions with the mental health community is referring patients that are in crisis or that come for requesting help, and try to get them to the service as quickly as possible. And for me, for that in that kind of situation, it's like, let's start with the initial presentation, and Then there's an assessment, identify, well, who are the providers, what types of providers, services are needed. I'll send the referral. Hopefully that referral is accepted. If it's not, then I'll have to find another provider, repeat that process, and go through this loop until finally the patient sees that provider. And that's something we can all do with a sticky note and a Sharpie and a blank wall. And but what are the typical problems that we see with that core process? So tech team somebody has to click on that OK so I can proceed. Thank you. Great. So waste a lot of time. And this is part of the reason why I still do, preserve 10% of my time doing clinical practice is I like to see what's actually going on in this system. And this is really frustrating as a provider. That often there's not an easy way, a directory or a list to find out what are the different services that are available. And sometimes it's just in people's head, and if the person on duty who isn't around that particular day doesn't have that information, then we struggle to find what's available. That we request a service only to find out it's not available, no longer available, or the wait time is so long that forget that, I have to find somebody else. Or situations where I send a referral and I don't hear anything back. Or I might get multiple rejections for the referral until somebody accepts them. Or and sometimes I'll send a referral where the patient actually goes, but then we find out that that patient is not eligible, and I have to start the whole cycle. So a lot of time wasted in this process. And I was speaking in preparation for this talk. I think many of you are service providers, and one thing that I heard is that you have some difficulty letting people know that your services are available, and they don't come to you, even though you could be providing some valuable help. So in any environment, it could be a large mental health facility, a hospital. It could be a community service agency. It could be a primary care group that has mental health services. It could be an addictions program. It could be any type of program. I think the key thing, and one of the things I would encourage everybody to do and tomorrow, is think systematically. What are the core processes, business processes, or operational processes that are critical or key to the day-to-day work that I do? So make a big list, or take this list and adopt it. So it's my referral processes, what I just mentioned. What does that referral process look like for getting services or sending somebody else? Or maybe, if you're on the receiving end, what is the referral reception process look like for you? There's the ongoing treatment and monitoring process. And again, managing wait times and appointment scheduling. What does that look like? And what are your process for counseling, or for healthcare teams or medical teams for doing periodic investigations or tests, or medication management? We do a lot of drug titration and changes. Is there a particular process that we have to make sure that that's done in the most efficient and timely manner? Crisis management is another core process. Or is there a process for coordinating the care with other professionals or healthcare organizations that we're working with, and particularly communication back and forth between primary care and other service providers? So and if you were to imagine now in your organization, now try to imagine what are those 3, 5, 7 core processes that are your organization. And let's just take a moment of reflection. Which of that list that I provided, what are the ones that are the core functions for you? And In your organization, do you have a written process map for each of those processes, just like what I showed earlier for that referral process? Is it actually on paper or is it just in everybody's head? And the second question is, are all of these processes, the most important ones in particular, are they actively managed? In other words, do you know, like at this particular moment in time, what the wait time is for that service? Or if there's an error, a common error that occurs, what's the error rate for that for that process or key steps in that process? Are you tracking those error rates? And if this is a process that involves multiple partners, either internally or externally, are you meeting with those partners regularly to flag issues, identify new system pressures, review data, and think, what's the next thing I'm going to do to improve that process? So please take a moment to reflect on these different questions. And again, I would love to know what your self-assessment is of your particular organization. Are you doing all of these four points? You know your processes, you got a map, you got data, and you're talking with your stakeholders to improve. Are you doing most of these, some of these, or being totally honest with yourself, little or none of these different areas? So please take a moment to record your vote on where you feel you sit on this spectrum. Okay, so getting some good results. I'm gonna got 60% coming in. I'll just wait to get a little bit more. Okay, I think we got about we're just over 70%. So let's share the results. So 57% said some, 3 said most, and 8% said little, and just 2% said they're doing all of these different points. So that's a point of reflection. Please take this home. Glad to see that there are some that are doing most, but for the majority, like, let's say 2/3, either little or some. I hope these are some important take home. Take them like tomorrow when you finish this conference, things that you can go back and think about how to implement in your work environment. So moving on. So another important, sorry, just double check. I did share the results. Is that right? I think. Yeah. So again, they're the results there. I think I might have not hit the button, but those are the results from that last poll. So another important development for process improvement and quality improvement is centralized intake process referrals. And I understand my preparation for the talk that's there's a lot of talk and activity to develop that type of a process. And there's a lot of good published data on the impact of that as a solution. And then just to a quick recap, what does that mean? That instead of my calling around to 5 different providers to try to say, can you take this patient? Can you take this patient? I go to one intake portal that will make those calls for me. So a single point of entry to access services. I go to one place, and then there's a common assessment. Typically, these are from the literature. These are typical components of a good centralized intake process. So there's a common assessment that evaluates all the different things that we want to know about the individual, about that person's needs. And then you also need to have a good inventory of what are the different services that are available in a particular region and their eligibility criteria for the people that they serve. And then and as well, you also want to know what are the wait times for each. You don't want to be sending somebody to a great service where the wait time is 2 years, and then you'll have to make a judgment as to whether or not you want to send them somewhere else where you can get the person in sooner. So facilities should be providing that type of information about those wait times. And then there's this process of matching the provider, the client, based on their common assessment and based on what's the inventory and the wait times information, and to select the best provider and get that magic appointment slip, and to be able to confirm that that referral has now been completed, and off we go. So those are the key components of centralized intake. And other common ideas for improving the quality of services. So there's different core change ideas, which also have their applications, particularly for mental health task shifting, particularly in areas where we have issues with low resources. Can we take a task that's being done by one provider and transfer it to somebody who's still well trained, but may be less expensive and may potentially have more time, so that the higher cost resource can focus on more complex activities. So a diversion to community care where possible, crisis services in the community instead of going to the emergency department. By the way, as an emergency doc, in the last 3 years, having a crisis team be the first person to evaluate somebody that it comes in a crisis, that has dramatically changed the way that patients have been handled in the emergency departments. That's something I'm particularly thankful for. Mental health checks using mental health staff instead of or with police. Care integration, having a common treatment plan or goals for clients across all providers. Appointment scheduling. A lot of this in literature is from primary care, but it got something called advanced access scheduling. We don't have time to go into detail, but essentially a whole package of different best practices to manage your schedule so that you work down your backlog, and then you try to shape the demand for the services so that it's as appropriate as possible, and you make sure that you are having appointments available when people at times of day when people most likely want to be seen, so they can be seen in even the same day if we can get to that point. Follow-up processes, a huge issue in all sectors, including mental health, about no-shows or patients who are lost to follow-up, and different strategies for everything from phone reminders, text reminders, calling, and other outreach activities to get to people. So those are all great ideas. Can you just follow a recipe book? Can you just take the literature and say, all right, those are all great ideas. I'll pick up the latest article on the centralized or common intake, and I'll just follow the cookbook. And can you just do that? Or do you still need those quality improvement basics for implementation? So you still need to follow, again, the basics. What can go wrong? Even if you take that great idea for common or centralized intake, you still need to have this mindset. What can go wrong at each different step? And what are the mitigating strategies? Simple way is a fishbone diagram. There's more complicated tools like failure modes, effects analysis. Tech team, can you press on that OK again so I can advance my slides? And then what are the ideas to address or mitigate those problems? So our centralized intake, what can go wrong with a great idea? So the single point of entry. Well, first you have to make sure all the referrers are aware of the program, and whatever portal that you have is going to be user friendly. The common assessment. So does the common assessment, has it captured all the important details. And that's always a balancing act, because if you put too many details, it may be so unwieldy that it takes too much time to fill out. So there's always a balance to do that. And sometimes there's design features that can allow you to capture those details in a tiered form, that, if you have one issue, then it triggers you to collect more detail in some other area. Access to up-to-date info on wait times for each provider. So you do need to have some system where people can tell you on a regular basis, right now my waits are up to 2 years, or it's 6 weeks, or it's a week. And it's very easy for that to get out of date. So anticipate that problem and figure out how you're going to quickly get that information if they don't want to submit that info. Or the inventory might be out of date. So what's your schedule for keeping that up to date, and checking in with different service providers about what services they've added or dropped in their portfolio? And is there a process for the confirmation? Is it not sent, or did the referrals get lost, or they didn't get to where it didn't get back to the patient? What are the ways in which you can continually safeguard against that? Now, getting back to I was anticipating the results of that earlier poll about those that are in large resource, medium resource, or smaller resources. But whether you're large resources, small resources, we're all part of a big system as well. And at a central level, a system level, there are people or organizations that try to do planning of that. And particularly if you're one of the small organizations, how can you make sure that you are part of that big system change? Because you are part of the system. But the changes, designing, whether it's creating a centralized or common intake process or any other system-wide intervention, that's going to affect you. So how can your organization be part of that particular change? Were you invited? And if you weren't invited, what do you do? So the questions we would ask is, have the system planners allowed for my input? Are they aware of the role of the services that I provide? Do I have an opportunity to participate in the process or system redesign? Do they think are they doing one-size-fits-all solutions, or do they just assume that I'm the same as other organizations? And have they applied the quality improvement tools in the way that I think they should be applied? So I'm just taking a page out of the rich business school text about managing up, where you are working with a boss, and you may not be crazy about the management style. The boss may be thrown into that situation, but you want to figure out, how can I have a constructive relationship and get what I need to thrive, and yet work well in the organization. So what are the strategic objectives? How can I align with the broad system-wide objectives? How can I form coalitions and group with other organizations, maybe a similar size with similar organizations, and come forward with a common voice? And how can I be useful to the central level or the system level? And if I have some local innovation, some local process improvements, how can I offer this as a model? Or how can I offer myself as a testing ground for different ideas? And having, of course, obvious dialogue and communication are problems. The power of probing questions as a way of getting engaged without people getting defensive is one of the critical skills to managing up. Measurement, I want to make sure I save some time for questions. You can't measure, but what if I don't have data? Of course, you can always use data, but I'm going to highlight a couple of things that are often underlooked in our management of data: defect check sheets, process tracer sheets, and mini surveys done in a small but frequent sample. But hopefully electronic, but even just manual in a pinch can still be powerful. And don't assume that your data system has all the information that you need, because you may still need to program new data in the system, even though you think you got all these fancy tools and and dashboards, you actually might not have the data that you need. So what's one of the most important things? The defect check sheet. And this is anybody who's gone online on Zoom or Skype or others, how was the call quality? And what were some of the different problems? That is a defect check sheet. At the end of an interaction or a process check-in, what were the errors in that? And what types of errors and what were the most common? So it's within your organization. Think for your core business processes that I asked you to identify earlier. Are you checking this? And I'll just give a quick example. I've worked for like over 30 years in emergency departments. The most frustrating thing is getting a patient transferred. There's mental health or other trauma or whatever, transferred to another institution. All kinds of headaches. Not once in my career I've been asked, how did that interaction to get transferred, that patient transferred out? How did that, what went wrong? What went well with that? Process tracer sheets, being able to identify, take a patient and follow their journey and have some way of time stamping the different, when certain things can happen. And in a pinch, you can do this on a small sample of patients on a regular systematic or block sampling. Can be done prospectively, or chart review. Prospective is better. But find out what those, try to keep track of what are those weights along the way for your patients. And mini surveys, 2 or 3 really simple questions at the exit of an interaction. Very similar, somewhat to the defect check sheet. Can be again a very powerful tool to get some quick data. I want to say very quickly, PDSA cycles. I mean, people have talked tons of this, but my point is, watch out for misapplications of this fundamental implementation tool. When I hear people say, I ran a 4-month PDSA cycle, or we studied the problem in the committee for several weeks and now we got a solution, that doesn't sound like a PDSA cycle. Your cycles need to be going like in days and weeks and dozens of different iterations. And the one tip I suggest, whenever you're implementing an idea, think who does it, in what order, where, and using which tool. There will be options for each of those different questions, and think, what's my preferred option at the outset, but I'm going to try different options in my PDSA cycle to see which one works the best. And the last point, there's so much we could cover today, but I just want to make a quick point. Understanding your stakeholder mapping and conflict resolution is going to be one of the most important skills that you can apply. And who are the different people involved in the process? And here are the key things I would ask. If you're implementing a change, does it result in loss of remuneration, loss of convenience, loss of time, loss of status or prestige, loss of a favorite task that somebody loves to do that you're taking away from them, changes to the work environment that make it lonelier or not as nice, or the loss of personal interactions because you made things more streamlined. Be aware of all those different things every time you make a change. And if somebody's going to lose, think, what's your mitigating strategy to address that for the purpose of ensuring its sustainability. I don't have time to go through all of the good examples. I did talk about joys of quality improvement and just following basic principles and pen and paper tools, but doing them really, really well can help you in any environment. This is just from one of a smaller project in Sioux Lookouts in the First Nations community, where we're developing a community health worker assessment program. But this is an example of lots and lots of PDSA cycles to test out the assessment tool that we were developing until we finally found something that was optimized and led to something that had as low an error rate as we could achieve. Another example, one of my favorite projects from my work in chronic disease management in Kazakhstan. This is from the WHO bulletin about how basically applying all these different tools around sticking to the basics and understanding process flows and collecting data that we're able to make some important improvements across the board in a variety of different quality and process indicators. So the key points, don't be discouraged. It's great to have lots of resources for QI, but don't be discouraged if you don't have it. You still do not need to put in time and effort. And even those big budget projects don't exceed if you don't follow to the basics. And that's my key point. Stick to the basics. Know your quality dimensions and pick a priority or one or two priorities. Go back and list all of your core processes and think, how am I going to actively manage them? And check, what's my error rate for that process? What's my monitor? What's my wait time? And to monitor that continuously, and using some of these simple data tools if you haven't implemented them already, and manage your stakeholders and resolve these conflicts. Use your PDSA cycles appropriately. Thank you very much. This has been I'm thrilled to have the opportunity to talk about these tools and approaches. Look forward to your questions in the Q&A. And Mr. Bell, I'll hand it over to you to facilitate that.
Thank you, Ben. You've given us a lot of guidance on building a quality culture, and it's a great way for us to start the day. We have time for a few questions, and we have 5 in the chat, so I'm going to try to summarize them a bit. One of our questions was around a list of tools, and so the way I would reframe that is, in any resource setting, what are the 1 or 2 critical components or tools that you would suggest people need to use to build their quality culture? And would you be able to provide us a list of tools?
So these are, like, we're talking about generic quality improvement tools.
Yeah, the question was a list of tools that we should explore further, and I'm assuming that where this was in the conversation that it was around the types of quality improvement tools that organizations should embed.
Well, I think there's 2 things. One, there's going to be tools, generic quality improvement tools for any topic, and then there's going to be specific emerging approaches that are for the delivery of care in a particular clinical area. Yeah, it's the basics. Create a quality improvement team and involve the key people involved that are part of the process. If I were to pick one quality improvement tool that I say the most important, the basic process map, the plain old process map, do that really, really well for all of your core processes. And all the other ones that you have in the E-QIPs, your Ishikawa diagrams, obviously that's important, but understand your processes really well. That would be one of the key messages that I would put forward. And then the other things that I said, the other thing that's often not mentioned is the conflict resolution piece. I wish I had more time to speak with that, but that's a key point for sustainability, because if you leave some unresolved conflict, like you implement a change and there's some group that doesn't like it and they're silent about it, that's the scary part. If they're silent about something that they don't like, then a year or months down later, you're going to create a workaround around the good work that you're doing. So you need, as a leader, to actively look out for and seek the opinions of people that might be more reticent to speak out.
Thanks, Ben. Another question really relates to equitable delivery of care. And, how do we make sure that the tools that we are using that are embedding the different social determinants of health, or, for example, tracking disabilities and the need for accommodation, to make sure that when we're delivering services and when we're doing quality improvement, that we are keeping our eye on equity?
That's a great question. And part of that relates to my earlier point. Like, do we really know how well our processes are working? Do we know? And that is across the board something that we are lacking, despite our huge investments in quality. Like, there's one program that I do want to do a shout out. It's the e-consult program, which I often use for mental health. And that's the only and it's an online platform. That's the only program that consistently asks me at the end of the interaction, did you have any problems with the connection? Did you get what you needed? And that's fabulous. I wish we did that for everybody, and particularly in the context of serving people with vulnerabilities or disabilities. You got to be able to create a system where you are asking them and accommodating their disabilities when you're asking them, how did that interaction that we just, the service that we just had, how did that go? What went well? What are some of the problems that we need to fix? And whatever disability they may have, whether it's visual or hearing or language or literacy, that data collection piece needs to accommodate those disabilities.
I think we can pull one more question together. So I'm going to try to combine two questions. We have a question around engaging staff and making sure that they're compensated for their time. I think that comes down to a question around how do we make sure that we have sufficient capacity in organizations and leadership buy-in to do QI. And so how do we make sure that we're not doing this on the backs of our staff?
That is a career-long, lifelong, a universal issue that I've had to deal with in my quality leadership career, that spans just about every setting that I have worked in. How do you convince the leadership or the fundor to invest in quality? I wish I had an easier answer to this other than go back. What is the leader or the leadership? What are their strategic objectives? And keep hammering that idea. If there's strategic objective, there's a financial objective, or if there is a quality objective that an overarching target, keep hammering that back. We are here to improve, to make you as the leader look good. And these are the resources that we need. And if we can back that up with any kind of a business case that this is the amount of waste that we want to reduce in the system that we will recover from our investment, or quite simply, you want this level of quality, this is what it's going to cost, and put it out there, then I think that's your best chance. Align with this, align with those strategic objectives and make a business case if you can.
Okay, I'm going to do one more question, and then I think we'll wrap up. We had a couple of questions around data, and one was around managing access and managing reports when you have staff turnover. How do we get access? But also, how do we use data well? How do we get good information from different types of data, including self-reported data?
So I did make the point, and this is a general observation. Sometimes there's a lot of data that collected that don't quite answer the quality questions that you're actually particularly interested in. So that way, the first thing is that, do you have that data that really measures that? So do you have the data on your error rates of the processes? Do you have data on the patient experience for a particular, a micro aspect of your service that you are trying to optimize? So for example, we have tons of patients experience survey. A lot of those questions are at a big picture level. But if you want to really improve big picture level, you got to do micro level improvements for service by service by service. And often we don't have that. So you need to be able thinking of how you can collect that type of